It's my pleasure to introduce our next speaker, Dr. Joe Osorio. Joe, yeah. So Dr. Osorio did both his medical school and neurosurgical residency at UCSF, and then went to a lengthy fellowship. Now he's the director of spinal deformity at UCSD, and has been doing a great job there. So he's going to give us the talk on management of kyphosis in pediatric and young adult patients.
All right, wonderful. Thanks so much, Lee, Lau, and Cal. Thank you so much for the invitation. It's my first time here. I'm really enjoying the conference. Great talks. So I'll be talking to you a bit about the treatment of kyphosis. I think one of my disclosures is that I don't treat pediatric patients, but I'll go over a little bit of the literature on that. So we'll go through the objectives in terms of operative indications, level selection, goals of surgery, and maybe I'll drop a couple of nuances that I think about when I'm doing surgery. I want to make it a little bit interactive, by show of hands. For a patient like this who comes into your clinic, they're 19 years old, they have an 85-degree thoracic kyphosis. These are their symptoms. They come in because they have pain. They do have some times where their pain is pretty significant, 1 to 2 weeks at a time, but it only happens about every 3 months. They're coming into your clinic. The mom mentions additionally, as you see the patient, that he has developmental delay. How many surgeons out here would actually treat this with a fusion? Fusion? Okay, great. So a couple show of hands for a fusion. So I'll go through and I'll circle back to this case towards the end. So the literature, does bracing actually work? There's a nice study out of the Italian group that shows that it does. Commonly for patients who are in their teenage years, so the mean age for this study was 14 years old, and they treated patients for 28 months. And so the time frames that you see there, where they started with a mean average of a 53-degree thoracic kyphosis, they were able to make a change of about 10 degrees. And that was at the end of the treatment, and then in their 10-year follow-up, it stayed around that 40-degree mark at 44. So they can use braces, and they do help, but not for all patients. When you look at conservative management, so when patients come into your clinic, physical therapy is often required, and embracing sometimes helps for the younger patients. Injection therapy for the adult patients and even RFA is something that we try at UCSD. But for surgery, if someone has persistent symptoms, they have refractory pain, they have curve progression, they're imbalanced in their sagittal plane, and they have a neurological deficit, that's when we're thinking about surgery. And if you look at the group out of Columbia, Zishan and Lenke published a paper talking about this, and they said that the indications really are around patients who have greater than a 70 or 75-degree curve, or if they have a thoracolumbar curve that's bigger than 25 or 30 degrees. If they have neurological deficits, or if they have cardiopulmonary compromise. So we would see some of these patients at Columbia where they would get PFTs and there would be compromise of their cardiopulmonary function, and we would see improvements after surgery. Cosmesis is something that Dr. Ames talked about yesterday, and it is something that comes up with these patients in particular. So I'm going to go through a couple cases, and we'll just highlight some of the nuances within my practice. So this is a 27-year-old woman. She came to me with progressive upper back pain. She was actually treated with a brace when she was a teenager. She had long-standing thoracic kyphosis, but now her pain was pretty significant. She had exhausted all the conservative measures. And when you look at her scan, she has an 84-degree thoracic kyphosis on her standing films. Supine really doesn't relax much. You can see it's 70 degrees there through the apex. She has the classic findings of Schmorl's nodes through her thoracic spine through the apex. How do we do level selection? So I used a sagittal stable vertebra, and you can see on the left film here where you actually do a plumb line that comes up from that posterior superior corner of S1. And you see where it touches the vertebra last. So you can see that last stable vertebra at that left standing film is L4. So you may be thinking that maybe your lower instrumented vertebra for a case like this might be L4, but if you look at the supine film, it's actually L3, and that helps to actually save a level for a patient like this. So the LIV for this patient's L3, and then choosing which level you're going to stop at the top, I like to provide symmetry. So if you look at the apex of the curve, you have about 6 intervening levels from L3 to the apex. Another 6 levels for a patient like this leaves you at T4. So I like to plan out these cases with pre-planned rods, and so that allows me to see exactly how many levels of osteotomy I'm going to use. And so you can see here that I do use some enabling technologies for certain points of fixation for constructs like this. For me, those distal segments matter a lot. Making sure that I'm getting maximal fill, I think, is important. Trying to avoid some of the soft tissues is important. So for L3, that first screw that I place, I usually do more of a transfascial screw there, so really sparing some of the distal dissection. And then sometimes when you get to some of the more difficult levels, L2 being one that sometimes doesn't give you the best corridor, but might be one of your bottom 4 construct screws, those are places that you can obviously really maximize what fixation you get if you're using some of your navigated techniques. Now, as you move along in the case, one of the things that I really like about using a patient-specific rod and having a plan where I know that I'm going to do 6 osteotomies is after I've done the exposure, I can lay that rod down and see where it deflects away from the spine. And if at that point in time I've gotten any relaxation from even the exposure, I know that I'm either going to be able to do less osteotomies or I'm still sticking with my plan. So I go through and I do the different osteotomies, which for most cases like this, they're just low-grade osteotomies, so Ponty-Smith osteotomies, type 2. And then for the correction, I tend to go from the patient's proximal down to the distal, and I'll show a slide on that after this. But if you're looking at this film, the head of the patient is on the left side of the screen, and the feet is on the right. You're looking at it from the perspective of the surgeon on the left. And commonly, I'll load several points of fixation at the top to decrease the stress of those upper screws. And I'll cantilever down. You can see that there's a watermark on that rod. And for me, what that does is it allows me to know that watermark really has to land on that last screw in order to achieve the correction that I had planned before surgery. But for cases like this, I'll go sequentially right to left, and I'll do the correction as I move my way down the spine in order to achieve the full correction. One of the things that I find that's important, I show the watermark here just in more detail so you can see it. One of the things that I find that's been nice and important in my practice is being able to use some of the intraoperative imaging to measure what correction I've actually had during surgery. And so I get this long cassette scoliosis film, and I'm able to measure, did I actually achieve that 44 degrees of correction that I was shooting for, or is it near target? So that if I'm finishing the case, I know that I'm going to get what I had expected as an outcome. And that's done pretty easily on the system that we have at UCSD. So you can see here, these are her pre-op and post-op films. And as I start to think about patients like this, and even I included this after hearing Ames's talk yesterday about cosmesis, because I remember the card that she wrote, but I'll read a couple little blurbs from it, because cosmesis for these patients really is a big deal. So she was a young, 20-year-old woman, and she comments here, being able to stand straight and tall has given me a confidence I had lost long ago. How good my clothes look and not feeling self-conscious about having my picture taken. And I don't have to have the fear of not being able to hold my future kids because I was so bent over. So it really matters a lot to these patients when they get that correction of being able to stand upright. Surgical nuances, I mentioned in terms of loading the rod. So when I have cases that end at the ilium, I tend to start at the ilium and then work my way proximally in the correction. But for cases like this where I don't end at the ilium and my LIV is somewhere like L3, I actually load the rod from the top and then work my way down. And so in a picture like this, if you have a construct on the right, which we're referring to now, I go from the top to the bottom. And one of the things that I find that's important is that often at the top of your construct for cases like this, those are the weaker points of fixation, the more proximal points of fixation, where the size or the path of your screw, if you're doing it in-out in, just isn't as robust as those distal points of fixation. And you're loading several segments as you cantilever down, and you're actually distributing that load quite well through those upper screws, really to minimize pullout. If you have a stiffer set of segments, one thing that's really helpful after you've done your osteotomies is going through with, we use a laminar spreader and just using it on both sides and going through and just really spreading open that space. If there's any osteophytes, it helps to sort of crack them open and get you a little bit more mobility for when you put your rod down and you do the compression sequentially. I mentioned those 4 points of fixation. I don't often use robotics for every single screw because it does take a little bit of time. But for those bottom 4 points of fixation, it does save me in terms of the dissection, and I feel like I get just one pass, which I think is important. And it really leads me to my next case, which is a case of initially when he was seen before. So he came to me when he was older than 17 after he had his primary surgery, but I'll show sort of the images from before his first surgery. So he was a teenager, 17 years old, had a Scheuermann's kyphosis, which you can see here, of 82 degrees. I think very appropriately, if you look at that sagittal stable vertebra, they chose L3 as a lower instrumented vertebra. And you can see here that just 1 week after surgery, he actually heard a pop and he had screw pull out down at L3. He didn't have very many symptoms from this, so he lived with this for another about 8 years. But ultimately, that rod was really pushing on his skin and he felt a lot of discomfort. So he went back to his surgeon and he had those bottom 2 levels removed because at that time the surgeon felt that with the CT scan, he was fused through those segments. But by the time he came to me, he was actually standing up like this, and he was actually unable to really stand straight, and he was sleeping on a table with a significant amount of pain, and now radiographically, this is what his standing films look like. So although they removed those bottom 2 levels, and he was fused at the time, over the progressive 5 years, all that disruption of the facets from their decortication ended up causing him to get another pretty significant distal kyphosis. So he was in a significant amount of pain. I mentioned here in that bottom HPI, he sleeps on a table because he's unable to lie flat, unfortunately. But overall, neurologically, he had an intact exam. For cases like this, I'll actually look at the CT scan to see whether or not their disc spaces are fused. And so he didn't actually have fusion through his disc spaces. And so I knew that if I'm able to recreate the mobility through those segments through posterior column osteotomies, I'm not going to need a 3-column osteotomy for a case like this. And so you can see here that bottom level where he had his screws removed at L3, he had significant haloing. Unfortunately, for a case like this with this much of a deformity, he's going to need a reconstruction that goes down to the ilium. Now, when I looked at a case like this, I'm thinking, gosh, can I get away with just a couple levels of PCOs? And so one of the things when you deconstruct a case and you're using planning software is you're able to predict, how much correction do you need and how many levels do you need to intervene on? And so I went through a series of iterative steps where I said, let's see if you can actually make that wedge osteotomy a little bit bigger through a low-grade osteotomy, and can we actually get a picture, that middle image, that I'd be satisfied with a standing radiograph. It seems quite aggressive, but it really is just going to take him back to his native alignment. One of the things that's important, and even for the trainees, is if you have an apex of your curve that you're trying to work on, why not leverage gravity? And so here you can see the white arrows where I'm really trying to space apart those pads, because once I'm working through the apex of his curve, I want gravity to pull down and a pad not to be in the way. So I don't want to put that chest bolster too low on this patient. And so here's his standing films. And once again, for a case like this, when I'm taking down that area of fusion mass, you can also additionally use those laminar spreaders to really loosen up that area so that when you cantilever that rod down, if you've created enough of a gap, you can get the correction that you desire. And so include his standing films here, his clinical films. He had a pretty significant outcome, and it was quite favorable. So mapping out a case, I think if I look through those last couple cases for kyphosis cases, a de novo case, mapping out a case for me really helps in terms of being able to understand what level of invasiveness I need, how many osteotomies are we planning on, and getting an understanding of their compensation. In terms of revision, you can deconstruct the spine and really start to understand what is it going to take in order to realign the spine and really look at different areas that might help. Allows you to target how much cervical invasiveness you're going to have really at the outset before you walk into surgery. So towards the end of the talk here, but circling back to this case to get a show of hands. So there wasn't a lot of hands for people who would intervene on this patient. I didn't know the patient when they were 19 years old. They're actually coming to me now. Same patient, they're 24 years old, still have developmental delay. Mom was pretty concerned because, they didn't have surgery, and he looks to be getting worse. We get a standing film. He now has a 96-degree thoracic kyphosis. And I have a couple arrows there because he has a significant amount of neck pain, and you can see why. He's sagittally not balanced. He can't even walk for longer than 25 minutes at this point. But just by show of hands, there was only a couple hands that would intervene on the patient previously. How many people would intervene on this patient now surgically? Yeah, I would agree with that. So this patient's someone that I have coming up in surgery next month, but I thought it was a nice case of someone who maybe would have met surgical indications radiographically initially. I could understand in terms of the surgeon, in terms of not exhausting conservative management initially, but they were sort of lost to follow-up, why they didn't intervene initially, but I think at this point, the cat's out of the bag. So when we think about kyphosis treatment, there's a lot of different treatments that are non-surgical. I think they're all worth trying, especially when you have a teenager. But obviously, once you meet operative indications, whether it's radiographically, you really want to make sure that they've exhausted all their conservative measures. But if they do have curve progression or they have neurological deficits, you might want to consider doing a fusion. The goals of surgery really are to achieve global balance and then preserve motion segments, but also to try to prevent the junctional kyphosis, which is so important. With that, I'm on. Thank you.
All right. Questions?
Joe, great talk. I have a question. In terms of indications for kyphosis, sometimes I see patients with relatively high PI, 60 degrees or so, and they do have thoracic kyphosis that's 80 plus degrees, but they're relatively asymptomatic. But then sometimes I see patients with very low PI, low 40 degrees, but their curve is maybe 70 degrees, and they're very uncomfortable. How do you can't use the absolute number clearly. How do you balance? Is it just all clinical? Do you have a threshold?
Yeah, no, it's a great question. I pay a lot of attention to PI these days. I think more so than even when I initially started practice, whether it's for kyphosis treatment or even other cases of deformity. The high PI patient can really compensate well. And so one of the things with cases like this, I pointed out in that case that I didn't show that I'm going to operate on soon, the developmentally delayed patient, I look at those other regions of the spine too. So what does their neck look like? Are they compensating so much that they're complaining of pain in other regions? I think the high PI patient is one that gets away with it, but the low PI patient actually probably more severely deformed. And so for those patients they're kind of right at that threshold, but they have a low PI, they're probably much more malaligned. And so for those, I'm more likely to offer surgery.
And then second question, for those patients with a type 3 spinal cord across the apex, do you always do PCOs, and then, if you have any neuromonitoring change, maybe consider a VCR, or do you ever go in with a thought of shortening the column and then kind of, lengthening the anterior column through?
Yeah, it's a great point. So sometimes what June's referring to is you could have a type 3 cord where you have the cord draped over the apex of the kyphosis. The areas that I worry about the most are more distal cord because the perfusion is a little bit worse in that area. I often do consent patients for a vertebral column resection if it's needed. But commonly I reserve that for, we talk about the deformity angular ratio. So if you take the number of segments and you look at what the degree change is, it's often used for scoliosis, but I think about it the same for these cases. If that ratio is over 15 to 20, that's a case, especially when I look at the MRI, if the cord's draped over and they have signal change, they might need a 3-column.
Yeah, I have a question. First patient. Did you, given the age of the patient, obviously we're always trying to figure out how do we get away with minimal to accomplish the same goal. Did you consider, or what are your thoughts on using a PSO instead? To do a PSO at that kyphotic level and then maybe just fuse 2 levels down without going to the pelvis? Is that something that you considered?
Yeah, it's tough because a case like that, he had such a big deformity that for someone who's young, you don't want to fuse them to the pelvis, right? And I think that that's where the outset of your question is. I don't often find when someone is like over 15 centimeters that I can get away with that. It's tough. It's tough that, you know, you're going to have a lever arm from, let's say, T4 all the way down to potentially L4, and you're doing a revision. And someone who has pretty haloed spaces at like L3, that I'm not going to get a robust 4 points of fixation. So when I don't have that much real estate to have 4 points of fixation, and it's that close to the pelvis, I often do reflexively go to the pelvis.
Joe, great cases. Yeah. Can you comment on, you know, the custom rods, and do you usually use tapered rods on top, and has that reduced the PJK rate to a certain degree from your experience?
Yeah, I do use tapered rods. It's something that that we saw a lot at Columbia with Lanky. He was using tapered rods, 5.5 to 6.0 tapered rods. I've now started to use 4.75 tapered rods. So 4.75 to 6.0, just to see if maybe just a little bit of added flexibility will help. The truth is that when you're planning these cases, the PJK rates are actually pretty low overall. So I think we have to have some aggregate data to really understand what the true benefit is. There are times where I'm dealing with a stiffer curve with some of these kyphosis cases where I'll get a non-tapered rod on one side and then I'll get a tapered rod on the other side just to try to minimize the stiffness of the construct at the top.
Thank you. Great talk. I have a question about the thoracic kyphosis, severe thoracic kyphosis, such as the 90-degree. Do you do resection of the cost-vertebral joint or cost-transverse joint?
No, I don't. I actually don't. I actually just do just classic type 2 osteotomies for that. I think if it's fused, that's the time I might think about doing that across that segment. But no, for the releases, it's really just type 2, just the facet joints and the ligamentum flavum, making sure that I have a gap in order to shorten the spine.
Okay, thank you.
All right, thanks everyone.